When you look at an X-ray of like a shattered femur, the problem is just entirely obvious.
Right,
You know,
right.
the bone is in two pieces. It's brutal, sure, but it's binary. You can just point to the jagged white line and know exactly what needs to be
Yeah,
fixed.
exactly.
But step into the world of hematology, specifically coagulation, and that comforting clarity just vanishes. You are suddenly navigating this diagnostic landscape that is entirely microscopic, highly volatile, and just full of paradoxes. I'm Harvey.
And I'm Donna.
We are your MCCQE reviewers, and this deep dive is designed to help you, the Canadian medical student, conquer one of the most, intimidating sections of the exam.
Oh, absolutely.
We'll be breaking down all major concepts covered on the exam regarding hemostasis and bleeding disorders, and we're pulling this directly from our stack of StatPearls medical articles.
Yeah, some really great sources today.
And since we are digging deep into clinical scenarios, please remember this deep dive is strictly for medical education. It is not medical advice, right? Any real-world clinical decisions should always involve a qualified healthcare provider.
Right, of course. So with that groundwork laid, the overarching mission today is pretty simple. We are going to tear apart the coagulation cascade.
Love it.
We are going to look at what happens when it fails to start, what happens when it goes completely rogue, and what happens when the biochemical breaks just fail. Because memorizing lists of symptoms won't save you on test day.
No, it really won't.
But understanding the exact mechanism, the why and the how behind the bleeding, that will let you atlasly reverse engineer any clinical vignette they throw at you.
Okay, let's unpack this by starting at the baseline, a failure to clot.
Mm-hmm.
To understand how the cascade breaks, we need to look at a condition where the body's clotting factory is missing a single crucial worker right from the moment of birth. Hemophilia A and B.
Right. And these are the most common severe hereditary hemorrhagic disorders you're going to encounter. Genetically, you're looking at an X-linked recessive inheritance pattern.
Okay.
So the genes encoding these specific clotting factors, they live on the X chromosome. Because a biologically male patient only has one X chromosome, inheriting that single mutated gene just guarantees the disease.
Wow, yeah.
But a biologically female patient with two X chromosomes generally becomes a silent carrier.
Right, and that genetic lottery is what gives hemophilia its famous historical context, right? Like Queen Victoria of England was a carrier.
Oh yeah, the famous disease of kings.
Exactly, and through her descendants, the mutation spread across like all the European royal families.
Right.
And long before anyone knew what DNA even was, a physician named Nasse formulated Nasse's law.
Right.
He observed that the disease was mysteriously passed from completely healthy mothers to their sons. But for the modern medical exam, the historical trivia kind of takes a back seat to the biochemical breakdown.
Yeah, they want the science.
So hemophilia A means the patient is missing factor VIII, making up about 80 to 85% of all cases. And hemophilia B is the absence of factor IX.
Exactly. And the clinical presentation isn't just a simple binary of, being sick or healthy. The reality of this disease for a patient depends entirely on a microscopic percentage of factor activity.
Just a tiny percentage makes all the difference.
It really does. We classified the severity by measuring how much functional factor is actually circulating in their blood. So mild hemophilia means the patient has between 5 and 40% of normal activity.
So if I have mild hemophilia, I might go through my entire childhood thinking I'm completely fine. Right.
Pretty much, yeah.
I mean, I play sports, I get scrapes. It isn't until I'm, say, 18, sitting in a dentist's chair, getting my wisdom teeth extracted, that the bleeding simply refuses to stop.
Right, because that small percentage is enough for daily life, but it utterly fails under surgical stress.
Wow, okay, so that's mild.
Then we drop into the moderate category, sitting at 1 to 5% activity. These patients might experience prolonged bleeding after relatively minor injuries. But the reality for a patient with severe hemophilia, meaning less than 1% factor activity, is just a totally different universe.
Yeah.
They experience spontaneous, completely unprovoked bleeding.
And the vignette on your exam will almost certainly feature the hallmark symptom, which is hemarthrosis, right?
Oh, guaranteed.
Leading directly into the joint spaces. So you'll see a toddler with a hot, swollen, intensely painful knee or elbow. And it's not just the immediate pain. Blood is highly irritating to the synovium. So repeated bleeds essentially digest the joint from the inside out.
Which is just awful.
Yeah, it leads to chronic hemophilic arthropathy and permanent disability. And in neonates, the most terrifying complication is an intracranial hemorrhage.
Right. And to visualize why this happens, we have to look at the coagulation cascades architecture. Factor VIII and factor IX, they work together to form something called the Tenese complex.
Okay, the Tenese complex.
Yeah. And their entire job is activate factor X, which then triggers the massive burst of thrombin you need to create a stable, cross-linked fibrin clot.
You know, I always picture the cascade like a major factory assembly line.
Oh, that's a good way to look at it.
Yeah, so the extrinsic pathway is your emergency fire alarm. Tissue gets damaged, the alarm rings, and a quick temporary clot gets thrown together.
Right.
But the intrinsic pathway, that's the heavy machinery deep inside the factory that fires up to mass produce the final permanent concrete product. So if you lack factor VIII or IX, that heavy machinery is unplugged.
Unplugged, yeah.
The alarm rings, the temporary clot forms, but the final stable concrete never gets poured. The clot just washes away and the patient bleeds.
Exactly. And that mechanical failure leads us straight into a classic MCCQE trap regarding newborn screening. Because if a family has a known history of hemophilia, catching it at birth is critical.
Obviously.
So you might assume you can just draw umbilical cord blood the moment the baby is delivered and check the factor levels.
Wait, if testing newborns is so crucial, why does the source say umbilical cord blood is only accurate for diagnosing hemophilia A, the factor VIII deficiency, and not hemophilia B? Like, why would a newborn's blood lie to us about factor IX?
It comes down to developmental physiology. So factor IX is a vitamin K-dependent protein, and it's synthesized in the liver.
Okay.
A newborn's liver is really immature, meaning all neonates are born with naturally low levels of factor IX. It takes roughly like 6 months for an infant's liver to ramp up production to normal adult levels.
Oh, wow. I see.
Yeah, so if you draw cord blood and see a low factor IX level, you might falsely diagnose hemophilia B in a perfectly healthy baby.
That's a huge trap.
It is. But factor VIII, on the other hand, is not dependent on vitamin K and does not require that same hepatic maturation. So a low factor VIII in cord blood is a definitive diagnosis for hemophilia A.
See, that distinction separates a passing score from a top-tier score. So when that patient is sitting in front of you, how do you definitively diagnose the missing factor? You obviously looking at the coagulation panel.
Right, and the hallmark finding is an isolated, significantly prolonged PTT.
Just the PTT.
Yes, the PTT essentially measures the speed of that intrinsic, heavy machinery pathway you mentioned.
Yeah.
Since the extrinsic alarm system and the platelets are perfectly intact, the PT and the bleeding time will return completely normal.
But if you're staring at an exam vignette, a prolonged PTT doesn't automatically mean hemophilia, right? The patient could have lupus anticoagulant, or maybe they were given heparin.
Right.
We need a way to prove a factor is physically missing.
Which brings us to the mixing study.
Yeah.
So you take a test tube of the patient's plasma and mix it 50-50 with a test tube of normal, healthy plasma.
Okay.
If the patient's PTT is prolonged simply because they are missing factor VIII, well, the healthy plasma immediately restocks the supply, and the PTT normalizes.
But if the PTT stays prolonged even after adding healthy plasma, it means something in the patient's blood is actively hunting down and destroying the factors.
Exactly. An inhibitor, which is exactly the concept we need to explore when discussing treatment, because once we diagnose the missing factor, we have to replace it. And man, the history of treating hemophilia is an incredibly dark chapter in medicine.
It really is. I mean, in the 1950s, a severe hemophiliac had a life expectancy of about 11 years. Just 11.
It's heartbreaking.
To extend those lives, medicine began pooling plasma from tens of thousands of human donors just to extract the clotting factors.
Right. And then in the 1980s, before advanced viral screening and heat inactivation even existed, that pooled plasma became a vector.
Right.
Between 60 and 70% of patients with severe hemophilia contracted HIV from their treatments, and nearly 100% contracted hepatitis C.
Oh, wow.
Yeah, the treatment that was meant to save them basically decimated the population.
That tragedy really forced an aggressive pivot in bioengineering, leading to the cloning of the human gene and the release of recombinant factor VIII in 1992, synthesized entirely in a lab, so no human plasma required.
Exactly. And modern management relies heavily on these recombinant products.
Yeah.
We divide it into acute and prophylactic care.
Right.
For acute management, particularly head trauma, the MCCQE expect you to know the golden rule. Replace the factor immediately. Do not send a hemophiliac with a head injury to the CT scanner to confirm a bleed before administering the factor.
Because time is brain tissue.
Yes. You infuse the factor while they're rolling down the hallway.
And prophylaxis is about keeping the patient out of the ER entirely, right?
Mm-hmm.
Using protocols developed in Malmo and Utrecht, patients receive routine infusions, sometimes every other day, purely to keep their baseline factor level above that severe 1% threshold. Bumping them from 0% to just 2% is enough to eliminate spontaneous joint bleeds.
It's amazing. And for patients with mild hemophilia A, we actually have an elegant alternative to recombinant factors, desmopressin or DDAVP.
Wait, how does a synthetic nasal spray suddenly give a patient the ability to clot?
It's so cool. DDAVP acts like a biochemical key. So, the endothelial cells lining your blood vessels contain microscopic storage pods called viable-Palade bodies.
Okay, fibrobulod bodies.
And these hold massive reserves of von Willebrand factor. DDAVP unlocks those pods. The cells just dump von Willebrand factor into the bloodstream, which then binds to, carries, and massively stabilizes whatever small amount of endogenous factor VIII the mild hemophiliac naturally produces.
Wow.
Yeah, it can temporarily boost their factor VIII levels 3 to 5 times higher.
That's incredible. It's cheap, it's effective, and non-invasive. But here is the trap for your exam. DDAVP is entirely useless for hemophilia B.
Right, because von Willebrand factor doesn't stabilize factor IX.
Exactly. So if you give DDAVP to a factor IX patient, you do absolutely nothing for their bleeding.
Nothing at all. And a quick note on pain management for any hemophilia patient. NSAIDs and aspirin are strictly contraindicated. Those drugs permanently disable platelets. And for hemophiliac, platelets are the only part of the hemostatic system they still have fully functioning. Destroying platelet function in these patients is catastrophic.
Yeah, don't do that. But let's talk about the nightmare scenario. You have a patient with severe hemophilia A. The recombinant factor therapy has been working perfectly for years. Then they come into the clinic with a massively swollen knee. The infusions have just stopped working.
They have developed inhibitors.
Right.
This happens in roughly 20 to 30% of severe hemophilia A patients, and it is the most dreaded complication in hematology.
Here's where it gets really interesting. I think of the immune system like a highly strict classroom. The regular teacher, endogenous factor VIII has never shown up to work. When you inject recombinant factor VIII, you are sending in a highly trained substitute teacher.
Huh, I like that.
But the immune system looks at this new protein, realizes it has never seen it before in its entire life, flags it as a foreign invader, and violently kicks the substitute out of the room.
That's exactly it. The immune system generates neutralizing alloantibodies, specifically IgG, that bind to and destroy the infused factor before it can even participate in the cascade.
Wow.
And we quantify the severity of these inhibitors using specialized lab tests like the Bethesda assay.
But if the immune system destroys every single molecule of factor VIII you infuse, how do you stop the patient from bleeding to death?
We have to outsmart the immune system. Historically, we use bypassing agents, basically flooding this system with activated factors further down the cascade. But the modern breakthrough you might see tested is emicizumab.
Emicizumab. It doesn't just bypass the problem, right? It kind of wears a disguise.
Yes, it is a bispecific monoclonal antibody. It physically grabs on to factor IC with one arm and factor X with the other, bringing them together.
Wow.
So it acts as the perfect molecular bridge, doing the exact job of factor VIII. But because its physical shape is an antibody, not a coagulation factor, the patient's inhibitors completely ignore it.
That is brilliant. It restores the cascade while remaining completely invisible to the immune system's bouncers.
Exactly.
Okay, so we've spent a lot of time on hemophilia, which is a chronic, predictable failure to start a clot. Now, we need to flip the script entirely. Let's look at disseminated intravascular coagulation, or DIC.
Oh boy. DIC.
Yeah, this isn't a genetic absence of a factor. This is an acquired systemic nightmare where the coagulation cascade is violently overactivated.
Right. The StatPearls source refers to DIC as a consumptive coagulopathy,
Right.
and it's always a secondary complication.
Always.
A patient never just develops DIC on its own. It is triggered by a massive, catastrophic systemic insult that forces widespread tissue factor into the bloodstream.
And tissue factor is the ultimate trigger for that extrinsic emergency alarm we talked about. So if tissue factor floods the entire circulatory system, the body panics and forms thousands of microscopic clots in every blood vessel simultaneously.
Right, and that microvascular thrombosis is the first phase. The tiny clots choke off blood flow to the kidneys, the brain, and the lungs, triggering multiple organ dysfunction syndrome.
Awful.
But the secondary phase is what presents so dramatically on the wards.
Right, because the clotting factory is running at maximum capacity in every single vessel of the body. It uses up all the supplies.
Everything. The sheer volume of clotting consumes all the circulating platelets, it depletes the fibrinogen, and exhausts every coagulation factor.
So the shelves are bare.
Exactly.
Yeah.
Once the shelves are completely bare, the hypercoagulable state paradoxically becomes a severe bleeding state. The patient begins oozing from their 5E sites, developing massive sheets of purpura under the skin and hemorrhaging internally.
And to catch DIC on the MCCQE, you have to recognize the underlying triggers, right?
Yes.
Severe sepsis is the prime suspect, particularly gram-negative bacteremia, which accounts for 30 to 50% of cases. The bacterial endotoxins essentially shred the inner lining of the blood vessels, exposing a massive amount of tissue factor.
Right. And severe trauma is another major trigger, especially brain trauma, because neural tissue is incredibly rich in tissue factor.
Right.
You also need to watch for obstetric emergencies. Placental abruption, amniotic fluid embolism, or severe HLLP syndrome can introduce placental tissue factor directly into the maternal circulation, sending a pregnant patient into DIC within minutes.
Terrifying. And the lab profile for DIC is the polar opposite of the neat, isolated PTT prolongation we saw in hemophilia. This is a scene of global destruction.
Oh, yeah. Because every pathway is exhausted, both the PT and the PTT will be significantly prolonged. The platelet count completely crashes.
Right.
The fibrinogen levels plummet because every available molecule has been converted into fibrin clots.
And the body isn't just sitting back while these clots form, right? It tries to fight back by releasing plasmin to chop up the clots.
Yes, fibrinolysis.
Exactly. That breakdown process generates a massive amount of cellular debris, specifically fibrin degradation products. So your D-dimer test will be completely off the charts.
And you also must look at the peripheral blood smear because you will see schistocytes.
Right, schistocytes are physically fragmented red blood cells. Imagine like pulling a water balloon through a tightly woven chain link fence.
Ouch. Good visual, though.
Right? The microscopic fibrin clots form webs across the blood vessels. So as the heart forces red blood cells through those partially blocked vessels, the cells are physically sliced into jagged fragments.
And that mechanical destruction is called microangiopathic hemolytic anemia.
Okay, so you have a patient bleeding from their eyes, their labs are a total disaster, and their red cells are being shredded. How do you treat them?
Right.
Because, what does this all mean for the patient in front of you? If the patient is bleeding out because they have no platelets or plasma left, shouldn't our first instinct be to immediately transfuse massive amounts of platelets and plasma to restock the shelves?
It is the most tempting mistake to make, and the examiners absolutely know it. But think about the underlying mechanism. If the gram-negative sepsis is still raging, the endotoxins are still shredding the vessels, and the tissue factor alarm is still blaring.
The factory is stuck in hyperdrive.
Exactly. So if you transfuse fresh platelets and plasma into that environment, you aren't fixing the hemorrhage. You are just delivering fresh fuel to a raging fire.
The body will instantly weaponize those new platelets, turning them into more microclots and worsening the kidney and brain ischemia.
Yes. The cornerstone of DIC management is, without exception, reversing the underlying trigger. If they are septic, you hammer them with broad-spectrum antibiotics and secure source control.
Right.
If it is a placental abruption, you must urgently deliver the fetus and the placenta. Once you remove the trigger, the cascade calms down, and the patient's liver and bone marrow will restock the supplies naturally.
So we withhold blood products completely.
Well, we use them extremely judiciously. You only provide supportive transfusions if the patient is suffering from life-threatening active hemorrhage or if they require an emergent invasive procedure.
Oh, that makes sense.
For instance, we generally only transfuse platelets if the count drops below 50 times 10 to the 9th per liter in an actively bleeding patient. But, that is just buying time. Reversing the cause is the only cure.
Okay, so we've covered failing to clot with hemophilia, and we've covered the consumptive chaos of DIC. But to fully master the hemostasis section of your exam, we have to swing the pendulum to the other extreme.
Hypercoagulable states.
Exactly, thrombophilia. This is when the biochemical brakes fail and the body forms massive, dangerous clots when it absolutely shouldn't.
And to frame any hypercoagulable state, you must start with Virchow's triad. It dictates that thrombosis requires at least one of three conditions: endothelial injury, stasis of blood flow, or a hypercoagulable change in the blood chemistry itself.
Right, so endothelial injury is the trauma like a major orthopedic surgery or a shattered pelvis. Stasis is the patient immobilized on a 14-hour international flight, allowing the blood to pool in the deep veins of the calf.
Right.
But the chemistry changes, the hypercoagulability, are where the MCCQE will heavily test your knowledge of specific diseases.
And we divide these into inherited and acquired states. The most common inherited thrombophilia in populations of European descent is factor V Leiden.
Let's look at the mechanism here because it's a brilliant biochemical trap. Normal factor V is a pro-clotting protein that accelerates the heavy machinery. Normally, to prevent infinite clotting, your body uses a protein called protein C as the brake pedal. Protein C comes along, binds to factor V, and disables it.
But in a patient with factor V Leiden, a genetic point mutation physically alters the shape of factor V. It still works perfectly to form clots, but the mutation makes it entirely resistant to protein C. Yeah, the brake pedal can no longer grip the machinery. The clotting pathway stays turned on, leading to deep vein thrombosis and pulmonary embolisms.
So dangerous. Another inherited defect you must recognize is the prothrombin G2210A mutation, which simply forces the body to mass produce way too much prothrombin, tipping the scales toward clotting. Or a patient could have a direct deficiency in the brake pedals themselves, right? Like antithrombin, protein C, or protein S deficiency.
Exactly. But the acquired hypercoagulable states are equally heavily tested. Malignancy is a massive risk factor. Adenocarcinomas often secrete mucins that directly activate coagulation.
Oh, right.
Oral contraceptives in pregnancy also dramatically increase clotting factors while decreasing anticoagulants.
And the most notorious acquired condition is antiphospholipid syndrome, or APS. This is a paradox you absolutely need to highlight in your notes.
Oh, for sure. APS is an autoimmune disorder where patients produce antibodies against proteins bound to phospholipids. The classic presentation is a young female patient with recurrent, unexplained miscarriages or unprovoked arterial and venous thrombosis.
And the paradox that the exam loves to test is the lab profile. If you draw blood from an APS patient and run a PTT, the test tube will show a significantly prolonged PTT.
Right.
In the glass tube, the lupus anticoagulant antibody interferes with the phospholipids used in the lab assay, making it look like the patient is bleeding.
But inside the human body, those same antibodies activate endothelial cells and platelets, causing aggressive, life-threatening blood clots. It is an in vitro bleeding test profile paired with an in vivo clotting catastrophe.
It's wild. So if you're sitting in the exam hall and the vignette describes a young woman with a history of miscarriages, a deep vein thrombosis, and a prolonged PTT that does not correct with a mixing study, do not diagnose hemophilia.
No.
That is antiphospholipid syndrome until proven otherwise.
And that perfectly encapsulates why understanding the underlying mechanisms of these diseases is so critical.
Exactly.
Whether it is the genetic absence of a factor in hemophilia, the consumptive destruction of DIC, or the failure of the regulatory brakes in factor V Leiden, the coagulation system is this incredibly delicate, high-stakes balancing act.
We've covered a massive amount of ground today. From the elegant, predictable genetics of X-linked hemophilia, tracing its royal history through to the triumph of bioengineered monoclonal antibodies.
Yeah, what a journey.
We contrasted that with the terrifying acquired chaos of DIC triggered by sepsis and obstetric trauma. And we closed the loop with the hypercoagulable states where the failure of our biochemical brakes leads to spontaneous thrombosis.
And, differentiating these based on the clinical vignette, the patient's history, the trigger, and the precise pattern of the PT, PTT, platelets, and D-dimer, that is the master key to succeeding in the hematology section of the MCCQE.
It really is all about recognizing the pattern. But before we sign off, I want to leave you with a final thought that extends slightly beyond our StatPearls text today.
Okay, let's hear it.
Well, we know that genetic traits often survive in a population because they offer some sort of hidden evolutionary advantage. The classic example is the sickle cell trait protecting against malaria.
Oh, right, the heterozygous advantage. It's a very well-documented phenomenon in genetics.
Exactly. So, it makes you wonder about hemostasis. Before modern lifespans, before we lived long enough for our arteries to harden with cholesterol, could the mild genetic mutations that cause slight clotting deficiencies have actually offered a survival advantage?
Oh.
I mean, in our modern world, cardiovascular thrombosis, heart attacks, and strokes are the #1 killers globally. We spend billions of dollars developing blood thinners. Could carrying a mild bleeding disorder actually be a bizarre natural shield against the thrombotic diseases of aging?
That is a fascinating way to look at it.
Just something to ponder during your next study break. Keep reviewing, keep connecting the dots, and we'll catch you on the next deep dive.